using the RAS approach. This is a plain chest radiograph of an anonymised patient. It is a PA film, and although it's not stated, I can presume this is the right side of the patient due to radiographic convention. The film is adequate. I say this because I can clearly see the apices of the lungs, right down to the bases, including the costophrenic angles on both sides. There is good inspiratory effort, as I can see more than 6 ribs anteriorly. The film is well penetrated. I say this because I can see the spinous processes of the vertebral bodies clearly behind the mediastinum. The patient is relatively well positioned, however there is some slight rotation as noted by the asymmetry of these vertebral bodies. Now, for a systematic approach, starting with the airway. One can clearly see the trachea here, however it is notably deviated to the right side. Now B, breathing. Looking at the lung fields, I can clearly see lung markings on the right side all the way up to the edge of the chest wall, throughout the upper, middle and lower zones. There is no obvious opacification in the right hemithorax. However, the same cannot be said on the left side. The left hemithorax appears widened compared to the right, and I cannot see lung markings up to the edge of the chest wall in any of the zones, upper, middle or lower. Indeed, there is a loss of lung markings throughout all zones of the lung, in combination with a soft tissue shadow centrally on the left mid-zone. Elsewhere, each hemidiaphragm appears clear, and the cardiac shadow is normal, the heart is not enlarged. I see no obvious soft tissue abnormalities and no bony abnormalities. There's no evidence of trauma. Now, in a radiograph such as this, it is prudent to go and discuss the most striking abnormality, often right at the start of your presentation. For example, one can say that the most striking abnormality in this radiograph is the loss of lung markings throughout the majority of the left hemithorax, in combination with a soft tissue shadow around the left mid-zone. These findings would be in keeping with a left-sided pneumothorax. One could then potentially go on to discuss the management of a pneumothorax, identifying the location of suggested needle decompression in the mid-clavicular line, second intercostal space. A more definitive management of a pneumothorax would be via the insertion of a chest drain by a suitably qualified professional, and hopefully this will help to reinflate the lung and restore normal anatomy and physiology to this left side. In summary, this is a plain chest radiograph of an anonymised patient with clear signs of a left-sided pneumothorax.